Tracy Kodak, the CEO, and my role here today is very easy and simple. I'm the moderator, and we are going to be discussing the current state of healthcare. This is our fourth of a four-part series, and today we'll be talking about specifically the healthcare workforce. And ironically, today, it was issued on Monday, but I just saw, and I'll put it in the chat, a statement or an advisory issued by the Surgeon General alarming or sounding the alarms for healthcare burnout. Not something that we did not know, but really basically saying that we are going to be in a struggle in years down the road for the healthcare workforce. So this is a very timely conversation today about the state of healthcare and where we are in workforce development and what we have to do to encourage individuals to join and go into careers in healthcare, payment models. So we'll be talking about that today. Healthcare Access Maryland is a nonprofit. We are based in Baltimore, but have served across the state with a mission of helping people enroll in health insurance, helping them navigate the healthcare system, and understanding their benefits and addressing social determinants of health. We are celebrating 25 years of Healthcare Access Maryland, so it's an exciting anniversary for us, and we have over 200 staff that help support that mission every single day. I want to thank our sponsors for the series, TriBridge Partners, Kaiser Permanente, and Window Nation, who supported our entire series, four-part series. So I'm going to go over to our panelists this morning. See if I can find them on here. There they are. For an introduction, and I'm going to start with Nicole Stallings, who's joining us this morning.
Great. Thank you, Tracy. And hi, everyone. I guess it's good afternoon now. Nicole Stallings, I'm the Chief External Affairs Officer at the Maryland Hospital Association. We are the state's trade association for all of the acute care hospitals, specialty hospitals in the state. I will note that every year we survey our executives about what is your top challenge. And for the past 4 years, the healthcare workforce has been at the very top of that list. Most recently, 91% of our hospital CEOs said it was the toughest challenge in the midst of a pandemic, certainly, but that's been ongoing. So I think this is a really timely conversation, and I'm looking forward to joining the rest of the panelists.
Thanks, Nicole. I'm going to turn it over to Whit.
I'm sorry, you cut out. I didn't hear who you said.
I was going to introduce you, Lisa.
Oh, okay. Well, thank you. Hi, everybody.
I'm in
Lisa Whaley.
a class on Sandra. I'm in a class right now.
Excuse me. I just want to ask everyone to please be muted if you're just joining us. We appreciate that. Thank you. Go ahead, Lisa.
All right. Thank you. I'm Lisa Whaley, and I am Senior Vice President and Chief Human Resources Officer for LifeBridge Health here in Baltimore and surrounding counties. I joined LifeBridge just before the pandemic happened, so I've officially been here a little over, I guess, about 2.5 years. I came here prior to that from a number of different organizations in a number of different places, actually, and for-profit and not-for-profit healthcare. And so I've really enjoyed getting to know Maryland and the healthcare health arena in the state of Maryland. And I'm very happy to be a part of the panel today. Thank you for inviting me.
Thank you so much. And finally, Dr. Wadis Daniels.
Hi, everyone. My name is Denise Wadis Daniels. I am the Associate Professor of Nursing at Coppin State University, located in Northwest Baltimore. At Coppin State, I teach pathophysiology and pharmacology. Also, I am the Director of the Simulation and Learning Resource Centers at this College of Health Professions. In the College of Health Professions, we have a nursing school, we have our undergraduate, as well as a master's prepared F&P program, and we also have a doctoral program for those interested in getting a doctoral degree in nursing at Coppin State. We also have health science, and we also have the health information management program, which is getting ready to start their master's program in fall. So that was my little advertisement for CSU.
Thank you. Always have to do a plug for Coppin. Wonderful. Thank you so much. So we're going to just kick it off today, and they're going to make my job easy, beautiful, and we're going to have a really nice discussion around the state of healthcare and our workers. So I'm going to kick it off with Lisa. What do you think is causing employment shortages currently, and where are the greatest areas of need in the healthcare system for workers?
Thank you, Tracy. I would have to start by saying I don't think there's any one cause. It's kind of been a perfect storm that kind of kicked off at the time that the pandemic happened. So everyone knows that there's a shortage for nurses. We were headed into a nursing shortage even prior to the beginning of the pandemic. There's a shortage for a number of the clinical professionals as well. Physicians now, as you mentioned at the beginning, we're seeing a shortage for physicians and other advanced practitioners, nurse practitioners and physicians assistants. And even respiratory care now, we're having trouble hiring in those areas and in the imaging areas. So it's not limited to just nursing anymore. And what is driving that? And I want to talk about the clinicians first, and then I'll come back and talk about non-clinicians. But I think that there are a number of things that are driving that shortage, particularly with the non-physician, non-provider group. I think a big part of it is the fact that we are seeing an increased demand for help, temporary help, and when that happened, as more vacancies occurred, the demand for agency and traveler help went up, and so that drove that rate that traveling agencies were offering for clinical staff up, and that then further enticed our clinical staff out of hospitals to agencies. So it kind of created that cyclical kind of need. And so that was one aspect. I think as the pandemic went on and on and on, and there was less support at the bedside and there was more turnover at the bedside, it created burnout for those who stayed at the bedside. And a number of those people, just a lot of them, decided to take early retirement or decided to get out of healthcare altogether. And I just saw last week, I think it was, a study that said that across the country, about 25% of all bedside nursing positions are currently vacant. So that creates then, a need across the country where we just don't have the resources to fill. So, and on top of that, you add in the increase in violence against clinicians, which further causes people to rethink their health choices. So, as I said, I think it's a variety of things, not any one thing that has caused people to choose to leave the workforce. Clinicians aside, we now have a real demand and a real shortage of non-clinical workers. So those entry-level non-skilled workers are also in short supply. And I think one of the big things that is driving that is that there are a variety of opportunities across the market for those type of workers as well. So we now are competing with non-traditional healthcare entities like Amazon and Walmart and even the fast food chains. As they're seeing a greater demand for those workers, they're increasing their rates of pay. So now we're competing with other entities that we've never had to compete with for that type of worker. And so we're finding ourselves in a crisis even at that level to find, the very basic workers to work in the supply chain area and to work in clinical support and housekeeping and food and nutrition. So the healthcare entities in general are really, I would say, the biggest challenge that we're facing right now today. Surely one of the biggest challenges is just where do we find the supply of workers to staff our hospitals?
Nicole, are you hearing across the state?
Yes, I wanted to put some numbers to it for a little bit of context, because one of the first things we did at MHA in this fall when we pulled together a task force to look at the future of our health workforce was figure out what the data are. And Lisa is exactly right. So in Maryland, we have a 25.4% vacancy rate right now for our RNs. LPNs even higher, 37.7%, and the list goes on. So certainly nursing is up there, but currently 1 in every 5 hospital positions in Maryland is vacant. So that goes to show that it's not just, one particular discipline. It's really across the hospital. And we know it's also across the state. Every region is experiencing significant vacancies. And as was noted, when we are that reliant now on agency staff, hospitals total $100 million a month to spend on contract agency staff right now. That was $50 million in January, and it's already doubled to $100 million a month. And I'll just remind folks, Maryland's hospitals, unlike any other hospitals in the nation, we operate under a fixed budget. And so we've got national problems just like everyone else, but we have something very unique that is a bit of a constraint for us, which I think makes this that much more of a challenge. I'll just underline one thing that was said. We had this shortage going into the pandemic that has been exacerbated. So we did some projections looking at the future. Nothing else changes. What are we going to need? By 2035, we need an additional 13,800 RNs alone in Maryland and 9,200 additional LPNs. This is on top of what we are currently graduating right now. And so we are well behind in this. Insufficient pipelines really impacting us. So we need to be creative, and we'll talk more about this, I think, throughout our time together on how are we going to address this? How can we build up that pipeline? How can we leverage our talent in new ways?
Thank you, both Lisa and Nicole. Really kind of setting the stage of the state of healthcare workers and support staff, really, because we recognize that it is not just the clinical team that makes the hospital run or healthcare facilities run. I'm going to switch it a little bit, but really transitioning over to needing that those schools to feed into healthcare workers. So how has the pandemic affected training and education of new healthcare workers, particularly nurses? Dr. Waddies-Daniels.
Oh, definitely the pandemic did affect us because we do most of our training in hospital based. And then the pandemic came. And so we had to transition out and we had to discover other ways of getting those clinical skills and building that confidence in our nursing students. It was very difficult. In the beginning, we all had to switch in such a great way. Students were not necessarily as prepared to switch to a virtual environment. I'm sure a lot of you are now even working from a virtual environment for the last 2 years. And so think about how that impacted education. Very difficult scenario that we had to deal with, but we did. And not only just at Coppin, but all schools of nursing in the state really did a yeoman's job in trying to get that done. So what we did, we had to use virtual simulations, virtual patient care. And then we also had to do some, as my dean would say, thinking outside the box. We had to identify other ways of having patient contact and getting those clinical skills in. So one of the ways that we did, looking at the pandemic, we hosted clinics to give the injections. We did testing. We did COVID testing, a lot of COVID testing on campus. We run the health center there. So we did a lot of COVID testing. We were in Under Armour in the very, very beginning when we were starting giving the COVID vaccine. Our nursing students were there. We also used community sites. They were during the summer. A lot of organizations hosted outdoor fairs, and our students came to do some blood pressure screening. We also did some health teaching in those areas, and we were always in contact with our health agencies seeking opportunities to come back into the clinical area. And we are there now, and we are definitely grateful that we are there. But it is also just getting our students up to a certain level of proficiency because of this gap in practice. And again, it's just not at our university. It's all over the state. And so I've been sitting on several different state level panels of educators and administrators looking at how we can fill that gap in our students and new nurses that are coming into the profession to make sure that they have skills proficiency, because that has been a problem.
And I will add to that in the hospitals that we did have to rethink how we orient new nurses as they come into the workplace and revise our orientation program to take into account the fact that they had less hands-on clinical programs during the pandemic, and take that into account so that we made sure that we were getting them competent and up to speed as quickly as possible, given the limitations that they had during their training and education and how different things had been prior to classes that had gone before them.
One of the other things that we did do was we hosted skills days, I guess you would call them skills days and skills proficiency days at school. So we knew our students could not get that on hands practice in the hospital, but we did use our resources. We used National League of Nursing resources and other agencies, federal and not federal, but national agencies, to give us lists of what skills, and we also asked hospital administrators, what skills do you think students need to have when they walk in the door? And so what we did host this semester and even last semester, these skills days that we had our students go in, and we definitely reviewed those skills with them, signed them off for those skills to make sure that they were ready or had a better foundation when going into the hospital.
Thank you both for that. And I know that will continue to be a challenge as we have the high demand of clinical nurses. Nicole, this is for you. The delivery care model, how has that had to adapt to meet the needs of the community and ensure staffing at the hospitals? You talked a little bit about the large volume of contractual employees.
Sure. I think we had to adapt right early on in COVID in particular, and it was about leveraging the talent that you have. And so we saw a lot of new team-based and nurse-led models starting to bring in more CNAs and LPNs back into the hospital. I think that's going to continue when we talk to our hospital nursing leads and others. It's really about ensuring that our nurses are practicing at the top of their license, and there are certain, be it administrative, lower level activities that they were being asked to do that we can bring in these other mid-level providers to support. But we do need to be careful with that reliance perhaps on LPNs or CNAs, that we don't cannibalize what our nursing homes need too, because as I mentioned, there are significant deficits and across the board in our healthcare pipeline. And so we need to be very mindful of that, because we don't want to create even more of a crisis and a pain point in one part of the continuum by trying to address some needs that we have. And so we need to be innovative. We need to be creative, certainly leveraging technology, telehealth, be it remote patient monitoring, telesitting, others. Those are things that I believe will continue. Looking at flexible staffing options, which we'll talk more about later, to ensure that we are keeping people at the bedside. But then there's been some really innovative things. There's been, we have one of our health systems has hired anyone who has 1 year of customer service experience, and then they come in and they act as that liaison to the patient, to their family, almost, taking questions back to the nurses. If it's something like getting them a blanket, things like that, that's actually been really positive, because it's just those things that typically are taking that nurse away from where we really want him or her to be. So that, we think, models like that, bringing family members in more to be part of the care team. That's something that we've been talking about. They do that really well in Europe. We need to pick that up and do more of that here. And so those are the conversations that we're having around our hospitals. But I'll just, again, kind of go back to needing to be very mindful that whatever we put in place with these new care models, we're not also inadvertently hurting other parts of our care continuum.
Yeah, absolutely. I mean, that's a great opportunity to also employ that customer service workforce that has also been hit through hotels, restaurants, where they were losing their jobs. It's a great opportunity to bring on more in the workforce in that area. Dr. Wadis-Daniels, we talked a little bit about what universities and colleges were doing to complete their clinical hours. You really kind of already touched on it. But what are ways that the community, right, so nonprofits that maybe have that clinical hours, a federally qualified health center that sees patients, what are ways that they can support getting those clinical hours in so that those nursing students are ready to be employed and go to work in the hospitals?
Oh, we are always looking for collaborations and opportunities to go with nonprofits. We are lucky at Coppin that we do have a nonprofit curriculum in the School of Social Work. And so we have tapped on various nonprofit agencies, community agencies. We have gone into senior citizens living areas. We have gone into or worked with other nonprofits in offering healthcare benefits, or not benefits, but healthcare assessments with our F&P students. We've gone into areas where they had soup kitchens, and we've also done some health assessment there, put on our own health fairs over time. And so we always look for other things. We understand, I think someone said it before, that when you go into a hospital, everybody is not at the bedside. I always tell my students there are about 1,000 offices in a hospital. Everyone is a little bit different. Find one that maybe suit your need. And so that's also how we look at healthcare. There are many different opportunities. Everybody is not at the bedside, and people need healthcare in various arenas. And so we do look for those opportunities in the community with nonprofits, with private organizations. We have to, because that's where the people are. And you go and treat the people where the people are. And all of them are not in the hospital. Some are in the community. Some are in a senior citizens home. Some are at an adult daycare center. Even in the peds area, some are in a children's daycare center. And so you go where the people are and deliver the health care.
Yeah, I know urgent care centers were also feeling the burn of being very busy. And so that would be another opportunity of where you could partner at the urgent care level. So with all these jobs, 25% RN vacancies, 1 out of every 5 positions at a hospital vacancy. Lisa, how are hospital systems, specifically LifeBridge Health, how are they identifying to be more competitive? Being the shiny penny, come work for us.
Yeah, so, with the changes that have occurred in the workforce that we've all been talking about, I think health systems are having to step back now and reassess what they've done for years in terms of programs and benefits and how even they pay clinical staff and even non-clinical staff, and reassess those programs and understand, does this fit the needs of the workforce now or the workforce of the future? And so some of the things that we've looked at, and I know that other health systems are looking at, are, becoming more flexible in terms of work hours, work locations. We at LifeBridge have created a workforce of about somewhere between 12 and 1,400 employees that are now full-time remote. So not all jobs lend themselves to that, but for the jobs that do, we allow flexible options and remote locations. We've reassessed the traditional hours because with the challenges that staff had during the pandemic with childcare and education, that they needed more flexibility to flex their hours. And so how could we become more flexible in terms of the hours, and looking at other things like childcare assistance, more flexible benefits, more choice around benefits, and accept the fact that, in the past, before the pandemic, we kind of had a one size fits all approach to benefits and other programs. But the workforce today is much more varied in terms of their needs. And so we've had to accept an approach that says, well, one size doesn't fit all. So we're going to have to break our workforce up into different segments and find things and ways that will differentiate us as an employer compared to our competitors. So what is that thing that would make somebody seek out and choose to come to work for LifeBridge as opposed to one of our competitors? We can only do so much with pay. So we can all, if we go up a quarter an hour, then our competitors are going to go up a quarter an hour, and we could play that game all day. But what is that secret sauce, that thing that would attract a segment of the workforce that says, apart from everybody else, LifeBridge might be the right place for me because they offer me whatever it is. And so for me, that makes this the value proposition.
Nicole, are you hearing other creative strategies we all know about the sign-on bonuses? HCAM has been hit by the great resignation of not just staff, but even our nursing staff, to take advantage of those sign-on bonuses. So other creative ways that hospitals are hiring?
Yeah, I would say there's not much that isn't being tried right now. Everything that Lisa mentioned, absolutely. Also looking at, any sort of loan repayment or training for, we don't talk about career ladders. We use lattices because you might be moving sideways, you might be going up. So really looking at that opportunity to not just bring someone new into the hospital, but also identify individuals and say, this might be a new role for you. And then putting those incentives and the appropriate structures so that they can be successful in that path. But one of the things that we've also done to keep people at the bedside is something our hospitals have been doing for quite a while with their patients, which is screening them for social determinants of health. And now we're actually trying to understand what are the social determinants that are impacting our own staff. And so you have hospitals that are hiring social workers for their own employees, because we have seen with great resignation, oftentimes it was women that were leaving the healthcare workforce, and that might have been for childcare needs in the beginning. One of the things that the Hospital Association did is we just reached out to our members to understand what the ages were of the children for their essential workers, and how could we provide childcare within the hospitals? How could we support that? Or when in Baltimore City, they were contemplating shutting down certain bus lines, we had to very quickly get pulled in. I never thought I'd be working on transportation, and but we had to very quickly pull in, because if people can't get to work, they obviously couldn't care for patients in the midst of a surge. But now it's not just in the midst of a surge. If transportation is really your key thing, that is driving your ability to get to work, then we need to help you with that. We need to help you with childcare. I've been scanning the country trying to figure out what are the really innovative things. So Truman Medical Center in Missouri, they realized that a lot of their staff were having to go out weekly and go to check cashing because they did not have bank accounts. And so think about all of that money that's going to those fees and the reliance on cash only stores. So they partnered with the bank to come in and said, you must establish a checking account for every one of our employees. And that just created such a sense of security for that staff and was a huge retention tactic. We often hear about community gardens. Well, what about letting your staff grow their own food, for themselves or to donate? You see that in other parts. So I think really trying to be innovative to bring in the healthcare workers, but also ensuring that we're keeping them once they come into the hospital.
We did some additional other kinds of support things as well, making available massages, chair massages during the day. We have a farmer's market that comes during the day. We actually hand out food boxes to make it easier for staff who work long hours to not have to cook when they go home. We also, another thing that's been really popular is to create employee resource groups around people who have like backgrounds. So, we have a Black and African American resource group, an Asian resource group, a veterans group, a LGBTQ group, an abilities group, a number of groups that connects people in a different way in the workplace. And then another cool thing that came out of that is we have forums, much like this one, where people get together and have a forum to talk about things that affect them personally and some of the challenges that they face, and people from all over the health system dial in and join to hear about the experience that those people share in bringing their authentic selves to work. And that's been one of those things that has really, it's connected people in a different way, and creating that connection, I think, has helped to deal with a lot of the burnout and the challenges that people have dealt with in a different way. And, so it's not always just about the pay, the benefits, but there is that. Oh, and the other thing I was going to mention, I'm sorry, we have a group called Katana that it allows people to join into a virtual support group for behavioral health. It's attended by a therapist, and they get behavioral health group therapy that you can just dial into and join, and you don't have to have an appointment. It's just when you're feeling the need, you can join in. I actually joined into a session just to see how it went myself, and I was actually very impressed. And it's not just folks from LifeBridge. There are other health systems that participate in this group.
And these things are really important because there are multiple studies out there now that are showing that for retention of employees, especially for the generations that are younger than baby boomers, that money is not important. I mean, it's not the number one thing that will keep you in your job. They want some autonomy. They want the opportunity to be more flexible. They want time off for working. They definitely, family and relaxation are ideas that are very important to them. And think about individuals that have to care for parents, aging parents as well. So these things need to be in the forefront when you are thinking about benefits for your employees. And yes, definitely trying to, nickel and dime, you're paying 5 cents more, you're paying $1 more. That you can't keep up with that. So you have to nurture people in a different manner. And money is not always the number one thing. Transportation, absolutely. Absolutely.
Yes, HCAM was actually having a conversation with one of the city hospitals right before the pandemic hit, actually, around their staff, that many of them were coming to HR with social determinants of health issues, such as paying rent, being able to get a cash advance on their paycheck, being in domestic violence situations. So there was conversation about having a social worker from HCAM actually embedded within the human resources department as a benefit. And I'm wondering, Nicole, your thoughts, if you think hospitals would take that opportunity now.
Absolutely. I would say, again, we've invested so much effort in doing this with our patients because we know that that's often what's bringing people into the threshold of the hospital, not necessarily their medical condition. That what is the saying that your zip code is often more of a determinant of your health than your genetic code. So when we think about everything that we bring to work each day, if these are the things that we need to identify to keep people thriving in their role, feeling recognized, appreciated, having that psychological and safety at work to really share what these concerns are, then that's where the investment needs to be. And so, absolutely, Tracy, I think that conversation is ready to be had.
It's good to hear. I know it wasn't ready at the time when we broached it originally, but I think the pandemic, as you had said, brought to light the strain on the healthcare system, but also health disparities and the zip codes that are being impacted, and the individuals that are living in those zip codes but are working in the hospitals and they're working in our healthcare settings. You guys are making my job so easy today with your just moving right through the conversation. How is Maryland's healthcare system advancing diversity and inclusion in its workforce? And what efforts are being made to provide opportunities for individuals from marginalized communities to enter careers in healthcare? So I'm going to kick it off with Nicole, but I'm hoping Dr. Wadis-Daniels will join in after.
So I would say, we've known for a long time that our healthcare workforce needs to reflect the communities that we serve. When we have provider, patient, racial and ethnic concordance, we see better outcomes, we see patient satisfaction way up. And in the end, that's going to help with disparities. We identified in particular a need to diversify our nursing population. And I just pulled up the numbers. So in Maryland, 11.8% of our population identifies as Hispanic or Latino, and yet 2.7% of our nursing workforce is Hispanic or Latino. So we have launched, we just took this to our board at our retreat just a few weeks ago and got this approved. We will be launching a multi-year targeted digital marketing campaign to really target that particular population and encourage them to come into nursing. This could be students, but it also could be someone mid-career that we are encouraging to, come over and to find nursing in particular as a career. But I think more broadly, we talked about this at the beginning, we've also identified the need, just to remind everyone, that it's not just you have to be a nurse or a doctor to work in a hospital. There are roles across the continuum of health sciences that track in particular. Like, we need them all. We need them all in our hospitals and everywhere else. And so there's a focus there. The other way that we want to really draw people into the hospital is to use our own staff as the best. That's going to be the best messenger. So highlighting our nurses, our rad techs, our environmental services, dietitians, others, and having them talk about why they love their career so much, we believe will also do a long way, because when people see themselves reflected and they see someone being very positive about their career, we just look at the J&J nursing campaign. Everything shot up in terms of an interest in those professions. And so we need to replicate that here in Maryland. And we've got some innovative partnerships that we are looking to launch to do just that.
That's very interesting, because universities are also looking at diversity in our student population. Coppin State University does educate almost 80% of the African American nurses in the state of Maryland, and our nurses stay in the state. So they're not being educated and going across state lines. They're staying here, taking care of the patients in our state. We also are looking at those numbers about the Latinx population in the state of Maryland, and especially Baltimore area. We are looking at ways of bringing more Latinx individuals into the College of Health Professions and the School of Nursing or in allied health. One of the things that we identified is that there has to be there has to be resources available before you do that. You got to have Spanish speaking people on your staff. You've got to be for that conversation, for the relationship, for the identification, communication, those kind of things. And so that's one of the things that we are working on, trying to find and hire those type, the people that fit that mold that we need to support the individuals that you have, because that has to be, people have to identify with those that are around them. We do have a very large international student body that are in nursing and other allied health professions as well. So that is a plus. Finding men, okay, men in nursing, definitely getting those male models, role models available. And we are fortunate in the graduating class this year. I think we had about 7 men in our graduating class. That was last Friday. So they're coming and we are supporting them, and we want them. We even have a male support group on campus, across disciplines. And that's really important, getting our male students involved in that as well. And also putting them in leadership positions and allowing and fostering them to go out and be that role model to encourage other young men and their peers to come into the healthcare area. And so, yes, diversity is very, very important. And there has to be various types of strategies to definitely get a population that's more reflective of the population of Baltimore.
Yeah, Lisa,
And I
was
would
going to
add
turn it
that
over to you. Yeah. Go ahead. Go ahead, Lisa.
I was just going to add at LifeBridge, additionally, 2 different additional things. One is that we found a pretty significant interest in the employee resources groups to reach out to their communities as mentors and representatives, as they want to help to encourage folks in their communities to come into health careers, and they're willing to step up and mentor. That seems to be a very effective way to get those programs going. And we also have a workforce development function here where we go into the schools in the community and start working even with juniors and seniors in high schools and target people from diverse backgrounds and try to encourage them to and help them with resources by offering them a career path. If they come in at the entry levels, there is a career path all the way through a clinical professional role if that's what they choose.
It's a great opportunity. I used to go in and talk about a career day at Fort Meade High School. My sister was a teacher there, and I would go in and talk about the career of public health, which would put every kid in the room to sleep because it's hard to wrap your head around public health. But nursing, clinical nursing, respiratory therapy, occupational therapy, imaging, I think would, those kids would be awake. But my presentations, they were always asleep. But I think there's lots of opportunities to continue to have those partnerships between healthcare and educational institutions. Are you hearing anything else, Nicole, across the state of how they're having different opportunities to promote it? I know you also originally in our conversation the other day talked about international opportunities.
Sure. So I would say, hospitals have had longstanding relationships with different, be it 4-year community college. Those are certainly being reinvigorated, and we're really thinking about even more creatively how to not just partner, but to address gaps. So, if we don't have enough clinical sites, then how can we work to do that, make that available at in an easy way to different schools, or how can we help grow nurse faculty, for example, where we continually have shortages. I would say, at the Hospital Association, we are an advocate in Annapolis and in DC for our members. And one of the areas where we just started to dip our toe, but I expect we will focus a lot more, is really paying attention to our education partners, to the budget that, is working its way through the General Assembly, to different policy changes where we can work together to support them so that they will then be able to help us. On the international side, we were one of 3 organizations that advocated to the U.S. Department of State to bring nursing in particular, but to have healthcare providers be a higher priority than they were currently being considered. And the Biden administration was very focused on unifying families, bringing families back together at the height of the pandemic. But we were able to, with the American Hospital Association, one other organization, advocate that we can bring that priority up. Now, it's not all the time, it's a case-by-case basis, but we were able to demonstrate the real need. We have also then started to look in Maryland to say, are we creating higher bars than we need to for these international students? Do we have language requirements that go beyond what our surrounding states do? And is that really helping or hurting us in our state, and making sure that we have communities that have healthcare providers that reflect their own race and ethnicity? And so I believe we'll have some advocacy in this space. This has been a real area of focus for the incoming chair of the House Health and Government Operations Committee. We partnered with her this session, and we'll continue to do that on these issues more around immigration.
And visas. We also had a issue with a student and had visa issues. They're here for a limited time in the country. That was a major problem during the pandemic. We had students that were here in the country for a limited time that had their visa stipulated they had to be in school, and it had to be face-to-face. It could not be on online program. Now we're virtual. How are we going to transition? How are we going to make sure this student can stay in the program, stay in the country? That was a big issue that we never even thought about that we would have to deal with. But we had some students that we really had to work hard with to make sure that they could be compliant to their visa requirements and also get through our program as well.
Yeah, things that we don't think about often that really create challenges for the students. And so are there other policies that you see, Nicole, coming through to address the Maryland's healthcare workforce?
So I think, there's been some attention of late to loan repayment. So this year in Annapolis, we established a nurse loan repayment program. We've had a physician loan repayment program for some time, and it's worked really well. And so when something works, you need to replicate it. And so we established and funded that for nurses. We're going to see that get off the ground. There's always discussion around scope of practice, and that's going to be really important as we look at these new care models as well. But I would say there's still some foundational policy work that needs to happen around ownership. Who within the state of Maryland has responsibility for ensuring that we have the healthcare workforce that we need in the future? When you look at the health licensing boards, they have a predominantly disciplinary focus, right? They're going to get you in, they're going to make sure everything's fine, and then it's discipline. They are not focused on growing their own, so to speak. That it has not been traditionally written into their statute and something that they need to work on. I came from the Maryland Department of Health before working for the Hospital Association, and there were bits and pieces scattered throughout, but there's not one singular entity that's understands what we have now, what we're going to need in the future, and then has the ability to get that coordination and ensure that we have the policies that we need. So, there's certainly kind of the stuff that we're used to, but I think it's really going to have to start with accountability. There's been a lot of attention to the healthcare workforce. We were the healthcare heroes in the beginning, and now there's a recognition of the shortages and the need to do something. at MHA, we're trying to make sure every legislator is aware of it, that the individuals that are running in, primaries, be it for General Assembly or for governor, understand that this is a real responsibility. And as we've talked about so much, when you employ people in healthcare, you can actually grow a middle class. You can bring people in at the beginning and then provide them the right supports and see them progress. And that's going to be good for communities, workforce development. It's going to be good for the state. So we need to make sure that there's continued attention to these shortages and a path to get to the future.
That sounds like a really good panel discussion for potential governors. Maybe the Hospital Association would want to host that.
Maybe we could partner with HCAM.
Yes, we would love it. We would love it. Any other comments, Lisa or Dr. Wadis Daniels, on at the policy level?
I think, as nurses, sometimes, and especially in schools of nursing, it's not until your last year, your nursing program, that we really do start talking about policy. And I think we need to maybe integrate that into our curriculums at a much early stage, in our leadership courses, in our nurse theory courses and things like that, that are usually at the end of the ethics, that are usually at the end of the program, really need to be integrated maybe an earlier, to understand that what we do is governed often by outside agencies and forces, the legislature, often who are not healthcare providers, are making major decisions about how we function. And so getting our students more politically aware, we have had some initiatives that our students did participate in, various I won't say campaigns, but we do have faculty that are working with the legislature, and doing some advocacy for healthcare areas. But we also need to get some students involved. We need to let the students know that this is important to you now, not later in your life, but now, that you can shape policy. And that is very, very important.
Absolutely. I'm sure you would have some guest speakers from the Hospital Association.
Absolutely.
Lisa?
A couple of things, that are from the hospital lens, that where we sit, that are near and dear to our heart, and I know that have been talked about at the Hospital Association and other circles, are just, in the future, in a situation like this, should there be some kind of limitation based on how much an agency can increase the rate or offer in order to attract staff away from a hospital. I'm not going to use the word opportunistic, but to take advantage of the situation and then possibly put our hospitals at a place where maybe they're not able to be staffed appropriately to provide the care that is needed at the time of crisis. And then the other thing is around putting better or stronger penalties against people who commit violent acts against healthcare workers.
People do hop from one position to another. Our crises in healthcare, I think it's greater now than it's ever been, but we've had a nursing shortage for many, 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 many years. And there have been many incentives from different agencies or hospitals that if you come here, you get this kind of sign-in bonus, and we'll give you this, and we'll give you that, and we'll give you the other. And we know that those kind of programs are not sustainable. They are for short periods of time, getting people to come in, but how do you retain them? How do you keep them in that agency? And there are some people that hop, that definitely, the next best thing, the next best thing. And it makes the whole work environment unstable. It makes it, because you can't keep up. You cannot keep up. And so you definitely have to have those that support, whatever that is. And there's, like we said, it's so multidimensional. Those things that will nurture and keep that person in your agency and not have them hop around, because it doesn't benefit anyone. It doesn't benefit them, and it doesn't benefit the patient care. Isn't that what we're all here for? Safe patient care. And it doesn't benefit the hospital environment, the just the morale. It doesn't benefit anybody.
Absolutely.
It's short term.
Absolutely. We're feeling it as well in the community health nursing as well. So we're recognizing those challenges. And for those that joined us a little bit late, in the top of the chat, I put the message put out by our Surgeon General, Dr. Murthy, on the impact to the healthcare. It was very timely. He put that advisory out on Monday with some suggestions around things that we need to do to improve that work environment. And one of the things that we talk about at Healthcare Access Maryland is let's find the silver linings that we've identified from the pandemic, lessons learned, new best practices that we came across by accident in dealing with the pandemic. We don't necessarily need to be in the office 5 days a week. There is an opportunity for a hybrid model. So can you talk a little bit about, kind of as your final remarks of lessons learned or new best practices that you're seeing? And I'll start with Lisa.
I would have to say probably the biggest one is that not all care has to be provided face-to-face, and digital and telehealth is, I think, here to stay. And I think that the population will insist that it's here to stay. And then that opens up a whole new world in terms of the workforce shortage. So if care is digital, then you don't have to have someone sitting in Maryland. You can, instead of bringing international nurses to Maryland, we can bring care to other people that are sitting in other countries as well. So it does change that aspect of the workforce. So I think that's certainly one. You mentioned the remote aspect of care. I think that's definitely a positive. And I think we learned a lot of things about ourselves. And one I think that will be a positive, we're not quite there yet, is the whole redesign of the healthcare delivery model, which will continue. I think will be continued because of the numbers that Nicole quoted. The shortage is only going to intensify, and we will be forced to redesign the health delivery model, which I think will ultimately provide better patient care.
Absolutely. Dr. Waddies Daniels, your lessons learned thoughts?
Oh, lessons learned. Lessons learned that in order to meet the need of your student, you definitely have to think outside the box, and that you can have to really search and look for opportunities to serve your public, to serve your people, not necessarily at the bedside. That there is a lot. I laugh because I am a critical care nurse specialist, spent many years at the bedside being a critical care nurse. And in the last 4 years, I have seen my personal practice shift to more community health. That's where the patients are. That's where we need to be. And so finding those opportunities again, and either developing a health fair on your own, or even participating in an established health fair or some kind of health initiative that is in the community, definitely need to get our students out there and to do that. And so we have also using simulation. I am the simulation coordinator. We have identified that you can literally simulate almost every situation you could possibly find in a hospital in a very safe environment, one that students can really learn in and not be afraid to mess up and make a mistake. As I tell my students, it's better to make a mistake here than to make it outside the walls of the university. So let's get in there and do that. It fosters a lot of critical thinking. Students absolutely love it. We're in a a group of students that like to game. So virtual simulation is almost like gaming, and they absolutely love it. So, and they can do it at home. They can do it at home. They can do it almost anywhere. And so again, shifting, knowing that everything is not face to face in a classroom, a traditional classroom setting, you have to take those opportunities to increase the knowledge of your students and have them gain confidence in being nurses.
And it is go into the community where the people are, as you said earlier. And Nicole, final lessons learned on your end.
So I would say, I think we realized that COVID was a real time accelerator. Like, we made gains in telehealth in a few months that had taken years to otherwise. And it also forced us to get out of our comfort zone, try new care models, but also looking at things as simple as the administrative tasks in an EHR and saying, do we really need to have this many clicks? And by taking a look at what your documentation requirements are, cutting out the stuff that was really extraneous, that gives nurses time to be back where they should be and operating at the level that they should. And so I think for all of us, it is important to identify those places where we either innovated, it was something new, or we honestly went back to basics, things that hadn't been in place in a while, and brought them back and to feel comfortable enough to say, this is what we need to keep doing. We need to sustain this.
Yeah, it's nice to be able to say, this is an improvement, that this is not necessarily a shortcut, but this is something we worked on, especially in the EHR space, because I know that's always a pain point for clinicians and across the board, even our staff, and ways that we can improve that. It's good to know that we're not going backwards, that we're learning from it and continuing to move forward. We do have a few more minutes. I wanted to make sure if anybody from the audience had questions, please feel free to put them in the chat for our panelists. But while we're waiting, I want to thank TriBridge Partners and Kaiser and Window Nation for supporting our series, as well as our panelists for joining us today out of their very busy day in the healthcare space. And thank you, Lisa and Dr. Wadis Daniels, for joining us today on this really important conversation and topic. I just want to give pause to see if anybody, you can also come off mute if you had a question. It's a quiet audience today. But we appreciate everyone, and thank you for joining us this afternoon, and have a beautiful day. I do want to ask panelists stay on for just a moment. Usually we get one question. Jordan, you can stop recording, I think.